So today my topic is regarding blood, physiology of hemostasis, and laboratory testing of coagulation.
Very good.
I present my topic under following headings, starting with introduction, then what happens when there is a vascular injury and the response to vascular injury, followed by there are three interrelated important structures which are involved or play a vital role in hemostasis. That is vascular endothelium, platelet, and the plasma protein. Next, I will focus on intrinsic anticoagulant mechanisms. What are counter-regulating mechanisms for coagulation? Followed by laboratory testing of coagulation. Lastly, point of care of coagulation testing. A brief note on point of care of coagulation testing. Coming to the introduction, hemostasis is an ordered, complex, enzymatic process involving cellular and biochemical components that function to preserve the integrity of circulatory system of a vascular injury. These are complex interrelated systemic mechanisms, and they operate to maintain a balance between a procoagulant and anticoagulant. The ultimate goal of hemostasis is to limit blood loss after injury and maintaining intravascular volume and promote revascularization after thrombus formation. So three important structures which are involved and play equal role are vascular endothelium, the platelets, and the plasma proteins. So any derangements in the above system can lead to excessive bleeding or pathological thrombus formation. So what happens when there is an injury? There are a series of events which occur due to injury. So vascular injury due to a mechanical or biochemical factors initiates these reactions. First, constriction of the blood vessels, followed by primary hemostasis. This is initiated by platelets, which forms a temporary hemostatic plug of platelets. These are sufficient for minor injuries, but when there is a severe injury, this platelet plug may not be sufficient to counteract the effects. So, which is done by secondary hemostasis, which are mediated by the plasma clotting factors to form a stable clot incorporating final cross-linked insoluble fibrin. Although the terms primary, secondary hemostasis, they are separate and relevant for descriptive and diagnostic purpose, but advances in molecular process suggest a far more complex interplay between the vascular endothelium, platelets, and the hemostasis. Coming to what is the role of vascular endothelium in hemostasis? In order to maintain a normal blood flow through circulatory system, the vascular endothelium employs several strategies to inhibit unnecessary thrombus formation. So, healthy endothelial cells possess antiplatelet action, anticoagulating action, pro-fibrinolytic effect to inhibit clot formation. So, what are the effects? How is vascular endothelium do this effect? First thing is negative charges of endothelium repels the platelets. Second thing is endothelial cells produce potent platelet inhibitors such as prostacyclin, PGI2, and nitric oxide. Third thing is they secrete adenosine diphosphatase, that is CD39, which are present on the surface of vascular endothelium, will degrade adenosine diphosphate. Adenosine diphosphate is a potent activator of platelets, which causes platelet aggregation. And the active metabolite of prophylactic cells selectively inhibits this step, ADP binding to its platelet P2 vital receptor, and also the subsequent ADP mediated activation. So, and next is there is also this vascular endothelium plays an important anticoagulant role through the expression of several inhibitors of plasma mediated hemostasis by increasing the activation of anticoagulant protein C via glycoprotein thrombomodulin which also acts as a thrombin mediator activator. Fifth thing where it causes anticoagulant effect in normal vascular endothelium are there are several inhibitors released by plasma, as already mentioned, and endothelium bound glycosaminoglycans such as heparin sulfate also functions to accelerate the protease activity of antithrombin, which degrades factor 9, 10, and thrombin. Lastly, vascular endothelium synthesizes tissue plasminogen activator, which is responsible for activation of fibrinolysis, that primary counter-regulatory mechanism limiting clot formation. So 1 to almost 6 steps are present which prevent the thrombus formation in intact vascular epithelium. So what happens when there is a vascular endothelial injury occurs? This vascular endothelial injury exposes the underlying extracellular matrix, which contains collagen, 1 Willebrand factor, and platelet adhesive glycoprotein. So these platelets get bind and get activated when they are exposed to extracellular matrix components. And also exposure of tissue factor whenever there is an injury triggers the extrinsic pathway of coagulation cascade, which results in thrombin generation and clot formation. And also certain cytokines are also released whenever there is a severe vascular injury, such as interleukin-1, human necrosis factor, interleukin-1, inducing prothrombotic changes. Finally, thrombin, hypoxia, high fluid tear stresses can also induce prothrombotic vascular changes. Coming to what is the role of platelets and hemostasis. Under normal conditions, platelets do not adhere vascular endothelium. However, when there is an injury exposing the extracellular matrix, platelets undergo a series of biochemical and physiological alterations which are characterized by 3 phases such as adhesion, activation, and aggregation. 1 Willebrand factor is an important bridging molecule between the collagen which is exposed during injury and a platelet glycoprotein 1B and factor 9 and factor 5 complexes. So platelets interact with collagen also serves as a stimulus for subsequent phase of activation. So during aggregation, activators are released, causes further recruitment of platelets and newly active glycoprotein 2B3A receptors on the platelets, causes bridging of fibrinogen, thereby promoting cross linkages and aggregation, and there will be followed by increased aggregation of adjacent platelets to form stable platelet plug. So importance of these receptors 2B and 3A receptors is important in syndrome where there are deficit or absent, leading to a clinical condition leading to transient thromboplastin. Coming to what is the role of plasma mediated hemostasis. Plasma mediated hemostasis was originally described as a cascade or waterfall sequence of steps involving a series of activation of enzymes and cofactors to accelerate and amplify fibrin generation by thrombin. Traditionally, it is depicted as extrinsic pathway, intrinsic pathway, both of them cumulatively goes to common pathway. Usual coagulation factors are synthesized by liver and they are circulated within the circulation as an inactive protein called zymogens. So what does this coagulation cascade do is it creates a series of enzymatic reactions in which the inactive precursors undergo a series of activation to active form and to overall amplify the reaction. So the ultimate goal is to produce thrombin and finally a stable fibrin insoluble clot. So the key regulatory step in the plasma mediated hemostasis or coagulation cascade is thrombin generation, also known as the thrombin burst. So in the picture you can see both the pathways, the extrinsic pathway and the intrinsic pathway. The extrinsic, whenever there is a vascular endothelial injury, tissue factor initiates this extrinsic pathway. Whenever this extrinsic pathway is stimulated along with tissue factor, and which further activates factor 7, which in turn further activates 9 and 10. During intrinsic pathway, this intrinsic pathway usually activated is the intrinsic system, the conversion of factor 7 to an active factor 7A. So activation in vivo occurs when the blood is exposed to collagen fibers under the endothelium within the blood vessel. So activating factor 12 then further activates 11, and 11 activates 9. So activated 9 forms a complex with active factor 8, which is activated when it is separated from one bilirubin factor. All these complexes, both intrinsic pathway and extrinsic pathway, finally they will activate the factor 10 from inactive to active factor. So finally the extrinsic pathway is triggered by the release of tissue factor or tissue thromboplastin, which is a protein phospholipid mixture which activates factor 7. So third important step in plasma mediated hemostasis is activation, that is common pathway for coagulation. Both extrinsic pathway and intrinsic pathway, they form the kinase complexes which will activate factor 10. So what is this common pathway? Final common pathway to both intrinsic and extrinsic factors depicts thrombin generation and subsequent fibrin formation. So what are the signal amplifies these reactions include factor 9, 8 and calcium ions, which are very, very important to activate this overall step. Finally, they form the prothrombinase complex, which converts the prothrombin to thrombin. This activated thrombin converts the fibrinogen to fibrin monomer, and all these insoluble fibrin monomers combine cross-linkers along with platelets to form a stable plot. For the conversion of fibrin monomer to cross-linked fibrin requires factor 13, that is fibrin stabilizing factor. So thrombin proteolytically cleaves fibrinopeptides A and B from fibrin molecules to generate fibrin monomers, which polymerize into fibrin strands to form a stable plot. So as already mentioned, thrombin generation remains the key step regulating hemostasis. Not only thrombin activity mediates conversion of fibrinogen to fibrin, but it also has a host of actions like it activates platelets and factor 13, converts inactive cofactor 5 and 8 to active form, upregulates expression of tissue factor, and stimulates vascular endothelium of plasminogen activating inhibitor to down regulate fibrinolytic activity, and also suppresses uncontrolled thrombus through activation of protein C. So this thrombin not only converts fibrinogen to fibrin, but also does the host of reaction. This slide shows how the plot is synthesized and progressed. First picture shows the normal picture. Whenever there is a vascular injury, it initiates and exposes the extracellular matrix, which contains tissue factor and wall Willebrand factor, which initiates a binding of platelets to collagen tissue factor dependent, and also tissue factor dependent initiates the extracellular pathway, followed by propagation. In propagation, there will be recruitment of platelets to grow thrombosis and also amplification of coagulation cascade. And finally, due to formation of platelet plug interaction with fibrin deposition, it forms a stable plot. Next slide. So what are the intrinsic anticoagulant mechanisms? Once activated, regulation of hemostasis proves essential to limit clot progression beyond the injury site. So there are 4 important counter-regulatory pathways have been identified to down-regulate hemostasis. First is fibrinolysis, next tissue factor pathway inhibitor. Third is protein C. Fourth is serine protease inhibitor. In the picture, you can see the fibrinolysis. The fibrinolysis compresses a cascade of reaction which causes plasmin generation and causes proteolytic degradation of fibrin and fibrinogen. So, principal enzymatic mediator in fibrinolysis, plasmin. So, plasminogen is converted to plasmin under the influence of PAI, plasminogen activator, tissue plasminogen activator, which converts the plasminogen to plasmin or urokinase. This tissue plasminogen activator is inhibited by plasminogen activator inhibitor. And the antifibrinolytics such as tranexamic acid work at this level. It prevents the conversion of plasminogen to plasmin. So it is used as a reduces the bleeding. And plasminogen, once it gets activated, it converts the fibrin into fibrin degradation product and acts as useful as an intrinsic anticoagulant. Next is tissue factor. Tissue factor and factor 8 form complexes to inhibit tissue factor, thus downregulating extrinsic pathway. Next slide. Protein C system downregulates coagulation by inhibiting thrombin and cofactor 5 and 8 by forming complexes with protein C. Next is most significant serotonin peptide inhibitors regulating hemostasis are antithrombin and heparin cofactor 2. This antithrombin inhibits thrombin factor 9, 10, 11 and 12. Heparin binds to antithrombin, causing conformational changes that accelerates AT-mediated inhibition. This heparin cofactor was recently discovered that inhibits only thrombin, whereas antithrombin, it inhibits not only thrombin but also other factors, whereas heparin cofactors only inhibits thrombin. Next slide. Coming to the laboratory testing of coagulation studies. Traditionally, perioperative coagulation monitoring has focused on preoperative testing to identify patients at increased risk for perioperative bleeding. And secondly, these tests are done to intraoperatively monitor the heparin therapy during cardiac and vascular surgery. Coming to the ideal test for perioperative coagulation, it should be simple to perform, accurate, reproducible, diagnostically specific, and cost effective. But present, no current coagulation monitors meets these expectations. Hence, there is integration of results from multiple forms of monitoring which may provide valuable diagnostic insights into perioperative coagulopathy. However, the current evidence does not support the routine unselected coagulation screening, which has a limited perioperative outcome, may delay surgery, and patient is subjected unnecessary parented tests. So, if the clinical examination history do not predict any increased risk of bleeding, then abnormal coagulation study will result in unlikely results, and need for routine screening should be judged. Next slide. So what are the specific laboratory tests for coagulation? It includes prothrombin time, activated partial thromboplastin time, platelet count and bleeding time, anti-factor 10A activity or factor 10A inhibition test, or thrombin time or reptilase time, fibrinogen levels, fibrin degrading product, and D-dimer. Next slide. Coming to the prothrombin time. What is prothrombin time? It is a time required in seconds for clot formation to occur after mixing a tissue factor, that is thromboplastin. So in prothrombin time, we will use tissue factor and calcium. So it assesses the integrity of extrinsic pathway. As already mentioned, extrinsic pathway is stimulated by tissue factor. So it assesses the integrity of extrinsic pathway and common pathway. This prothrombin time is sensitive to deficiency of fibrinogen, thrombin, factor 5, 8, 7 and 10. However, it is most sensitive for factor 7 and 10. When you see these factors, out of all, 3 factors are vitamin K dependent. That is 2, 7 and 10. So prothrombin time assays has been used to monitor anticoagulation with vitamin K antagonist such as warfarin. Coming to the INR. So thromboplastin, which is the reagent used during measurement of prothrombin at different labs, can vary in its ability to bind factor 7. So thromboplastin, which is used, will vary from lab to lab. So there will be inter-lab comparisons, and also which will limit the prothrombin time. Due to this, the internationally accepted measures are developed by WHO, which include international normalized ratio, a method to a means of normalizing the PT results among different labs. INR is calculated by patient PT divided by standard PT, which is usually normally 11 to 13.5 seconds. So whenever there is any prolongation of PT, you should assess further why there is a delay in clot, due to whether it is due to coagulation factor deficiency in the patient's serum, or whether due to presence of any inhibitor such as antiphospholipid antibody or fibrin degradation products. How will you assess these things? First, you collect the patient serum and mix with the known donor patient serum sample. So whenever there is delay, it is due to antiphospholipid antibody. When there is no delay, it is normal. It is due to coagulation factor deficiency. Because in normal serum, the patient contains coagulation factor, which causes normal prothrombin time. But however, when there is antiphospholipid antibody, it is not present in donor, so it gets prolonged. What is the clinical significance of prothrombin time? As already mentioned, it is useful to monitor oral anticoagulant therapy with warfarin. Whenever the patient requires warfarin due to deep vein thrombosis or due to any condition, the therapeutic goal is to achieve 2 to 3 seconds. So, when 2 to 3 seconds. So, the prothrombin time normally is 11 to 13 seconds. 2 to 3, it comes upon 45 to 100 seconds. So, this is the normal prothrombin time when the patient is on warfarin therapy. So, based on these measures, we can adjust or increase or decrease the dose of warfarin therapy based on this prothrombin and INR ratio. Coming second important clinical significance is whenever the patient has vitamin K deficiency. So this prothrombin time is increased. And in case of liver synthetic function, decreased liver synthetic function also, prothrombin time increased. And the patient is having disseminated intravascular coagulation or decreased factor 7, also this prothrombin time is increased. Next slide. Coming to the activated partial thromboplastic time, APTT. It assesses the integrity of intrinsic pathway. Whereas PT assesses the integrity of extrinsic pathway, APTT assesses the integrity of intrinsic pathway and common pathway. This is the APTT is the time required in seconds for clot formation to occur after mixing the patient plasma with calcium phospholipid and the activator of intrinsic pathway, that kaolin silica or This test is more sensitive to deficiency of factor 8 and 9, whereas PT is more sensitive to 7 and 10. APTT may sometimes cannot prolong until the level decreases below 15%. And when unlike APTT, there are no standards for PT, there are no standards for APTT like INR. So institutions set their own normal ranges and cannot be compared between labs. The normal range is usually between 30 to 40 seconds. Coming to the clinical significance. So it is useful to monitor therapy when unfractured heparin is used, and it should be targeted at least 1.5 to 2 times the normal. And it is also useful for hemophilia A, B and C. That is hemophilia A is due to factor 8 deficiency, B is 9, C is 11. And also it raises in conditions of lupus anticoagulant or phospholipid antibody syndrome. Coming to bleeding time and the platelet count. It remains one of the standard component in screening for coagulation studies, reflecting only quantity but not the function. So platelet count only quantitatively can determine, but not the function of the platelets. Usually normal range is 1.5 to 4.5 lakhs per cubic millimeter. Spontaneous bleeding is less likely with counts more than 10,000 to 20,000. Surgical bleeding may be severe with counts from 40,000 to 70,000. For certain procedures like neurosurgeries, bleeding can occur with count 1 lakh to 1.5 lakh. There are no current recommendation what is the safest level, but the current guidelines say more than 1 lakh causes normal coagulation, most of the cases. So satisfactory platelet plug will not be formed if the count is too low or functionally inert, such as during cardiopulmonary bypass or during blood stored more than 3 months, patients on aspirin or uremic patient. Platelet count is crucial for patients on prolonged therapy on attraction heparin, usually more than 4 days. So due to heparin-induced thrombocytopenia. Abnormal low platelet count requires further assessment like visual platelet count from blood smear to determine the actual cause. So sample hemodilution and platelet clumping are common etiologies for falsely low platelet count. Bleeding time will assess the platelet function and normally 2 to 9 minutes and measures the overall hemostatic role of platelets and primary hemostasis. Coming to anti-factor 10A activity. Anti-factor 10A activity or factor 10A inhibition test commonly used for heparin anticoagulation. These APTT values are also used for heparin. However, there is difference between both these concepts. APTT values are usually affected by several factors, including patient factors, coagulation deficiency, or any factors inhibitors present. However, heparin bound AT inhibition factor 10 is not influenced by this variable. So it depends only on heparin and bound to antithrombin. So other advantage of this test is it is used to measure like other anticoagulation, not only unfractured heparin, but also low molecular heparin like enoxaparin or fondaparinux. The process involves combining the patient plasma with reagent. So look for factor 10A cleavage, which generates a colorimetric signal, which is released and is functionally by calculating this, we can functionally assess the heparin anticoagulation. Coming to thrombin time and reptilase time. Thrombin time tests the ability of thrombin to convert fibrinogen to fibrin. So normal value is 15 to 19 seconds. TT may be prolonged in conditions affecting the fibrinogen or thrombin. For example, in hypofibrinogenemia, when there is less than 100 milligrams per deciliter, or advanced liver disease, heparin therapy, or direct thrombin inhibitor and fibrin degradation products. So in contrary to reptilase time, this reptilase is a venom used. It is an enzyme which is found in the snake venom. The action is similar to thrombin. So why this reptilase time is used? This reptilase time is used to distinguish between the effects of heparin and fibrin degradation products. So in the TT fibrin degradation product, normally this reptilase time indicates the presence of heparin. Elevation of both thrombin time and reptilase time denotes low fibrinogen levels or presence of fibrin degradation products. So whenever there is TT is prolonged, it is mostly due to heparin. When the reptilase time is prolonged, it is denotes mostly due to low fibrinogen levels or presence of FDP. Coming to the fibrinogen level, the normal fibrinogen level is 160 to 350 milligrams per deciliter, mainly produced by liver, and less than 100 milligrams per deciliter are inadequate. Low level reflects reduced production, as in hereditary hypofibrinogenemia, liver impairment, severe malnutrition, or due to increased consumption, as in DIC. Fibrinogen consumption without DIC is an important cause of severe bleeding in patients with blood loss after major surgery. Coming to FDP, fibrin degradation products and D-dimer. Measurement of this fibrin degradation product will detect the degradation products of both fibrin, both cross-linked and uncross-linked. So when you measure FDP, it indicates both cross-linked and uncross-linked. Whereas D-dimer specifically for degradation products of cross-linked fibrin only. So excessive fibrinogen results in increased FDP levels in conditions like advanced liver disease, exogenous thrombolysis, such as administration of streptokinase, and fibrinolysis during cardiopulmonary bypass. However, D-dimer reflects widespread lysis of cross-linked fibrin of established thrombosis, such as in DIC or deep vein thrombosis and pulmonary embolism. Normal value less than 250 nanograms per ml. Coming to the brief note on point of care testing. Point of care testing is a rapid specific testing of body fluids at bedside. Results can be obtained within minutes without delay as in laboratory testing. So it offers opportunities to direct blood components and hemostatic drug therapy more specifically. Done with whole blood at patient's temperature, unlike laboratory testing which uses plasma. They are classified broadly into 4 categories. First is functional measurement of coagulation that measures the intrinsic ability of blood to generate clot, that is activated clotting time. Next is heparin concentration measurements techniques, and third thing, viscoelastic measures of coagulation, that's thromboelastogram and ROTEM, rotational thromboelastography. So fourth thing is platelet function monitor. So all these are broadly classified under point of care. Take home. Normal hemostasis is the balance between generation of localized hemostatic clot and uncontrollable thrombus formation. The extensive pathway of coagulation begins with exposure of blood plasma to tissue factor and represents the initial phase of plasma-mediated hemostasis. However, the intrinsic pathway amplifies and propagates the hemostatic response to maximize the thrombus generation. The common pathway generates thrombin, forms fibrin, and cross-links fibrin strands to produce an insoluble fibrin clot. Routine preoperative coagulation testing of all surgical patient is costly and lacks predictive value for detection of hemostatic abnormalities. Testing should be based on the preoperative history and physical examination and planned surgery. Thank you.
Thank you. It's a very nice presentation giving most of the theoretical descriptions that are required to understand hemostasis. But one thing I find missing is about the so-called the coagulation cascade involving the extrinsic pathway, intrinsic pathway, culminating into the common pathway. Was later on replaced by cell-mediated theory. I think you have not mentioned anything about that. So the current concept is to accept the cell-mediated therapy. Do you have any idea about it, Rao? What is cell-mediated theory of coagulation?
Extrinsic, intrinsic, and common pathway.
That is the old coagulation cascade theory. Then later on it was modified because it had some deficiencies of not able to explain the classical role of factor 7 and also why people with factor 12 don't have any bleeding. All those questions were raised which were not answered by the old theory. So they proposed a theory called cell-mediated theory, and so that was the which says that all steps are overlapping. It is not like the mathematical equation shown in the older coagulation cascade of extrinsic intrinsic. These steps overlap to each other. That is the main basis of that, and it is initiation propagation and amplification. That is how they describe. Instead of the intrinsic, extrinsic pathway and common pathway, they call it as initiation, amplification, propagation, and amplification. These are the three steps which are held in the extrinsic pathway.